All right, today we're going to talk about the summary of the March 2026 EMS training. We mainly talked about shock, and so we're going to talk through each of those pieces, and then we talked also a little bit about pacing patients, so we'll talk about that just a little bit as well. So first we'll talk about shock. We need to define shock. That's a very non-specific term. People use it, lay people use it for you're surprised, you're not thinking clearly. So when we're talking about shock, we're talking about decreased perfusion. Pretty much all these different types of shock involve tachycardia and hypotension. Neurogenic actually has bradycardia, but just about otherwise, typically you're going to see patients that are tachycardic, but they're all going to be hypotensive. So first we'll talk about is hypovolemic shock. Typically thinking about trauma patients. So in the right clinical context with blunt or penetrating trauma, and you expect some bleeding, there's a large pool of blood at the scene, you suspect that you have internal bleeding, again, depending on the mechanism, you're thinking hypovolemic shock. Can also happen with patients with severe like gastroenteritis, severe nausea, vomiting, diarrhea. I mean, the average person with a couple hours of nausea, vomiting, diarrhea typically isn't going to be hypovolemic from that. But if it is very severe, you certainly can get hypovolemic shock from that. But I would say clinically we see more patients with hypovolemic shock related to trauma, probably more than anything else. We've talked about using ultrasound in regards to trauma, and again, it doesn't, ideally if you can use it, yes, use it, but again, we're going to talk about ultrasound with all these things. The ultrasound is not therapeutic, it's diagnostic. If it's going to change what you do, and you have time, it's a good thing to try to use, right? And I acknowledge that I get that you're not going to use this on every patient all the time. If you do roll into a trauma center and say, hey, I think they have a positive FAST, hey, I'm pretty sure they have a pneumothorax, maybe it wasn't a tension pneumothorax, you didn't have to treat it. But if you can say, hey, we looked on the way here, we didn't see any sliding on this side, again, in the right clinical context, that should direct the ER doc to then focus on that area to deal with that issue. Again, if you think, hey, I think I saw a positive FAST, and maybe you only get one view, maybe you just get Morrison's pouch, it's going to change things when you get to the ER because they're going to immediately key in on that and probably check it themselves. So again, if you can use it, great. If you're already going to a trauma center, it's maybe not the priority, right? I get that. So when it comes to really, really bad trauma, the big thing is access and IV fluid. We're not going to flood them with a full 2 liters necessarily. We're not going to pour in 3-4 liters, but they need access. The bigger, the better. Get what you can. When they get to the ER, they're going to get blood if it's really bad. If it's confirmed, yes, this is indeed hypovolemic shock from bad trauma. They're bleeding somewhere in their chest and their abdomen, maybe a bad femoral injury. If they're bleeding out, they need access. The sooner they have good access, like if they hit the door in the ER with good IV access, they can get the blood going. They have a level 1 transfuser, they have blood in the fridge, they can get blood going in a hurry. If they get to the ER and they have a 22 gauge in their hand, we didn't do very good. So get what you can, the bigger the better. Access, and then start getting some IV fluids in there. So distributive shock, sort of 3 main types of distributive shock. And distributive being like the vessels, the tank is too big. Like the vessels are all dilated and there's just not enough volume in the tank. You didn't lose the fluid out of the tank like in hypovolemic shock, but the tank is too big. Anaphylaxis, the treatment there is obviously epi. That's the thing that solves that. We talked a little bit about Benadryl, steroids. You can give those, they're going to get them in the ER. Both Benadryl is mainly for itching. It doesn't really do anything with the physiology of shock and the vasodilation. Steroids are for the inflammatory process that is probably still going to be ongoing from whatever the antigen that caused the anaphylaxis in the first place. So they're going to get Solumedrol, they're going to get prednisone. Solumedrol and prednisone work about the same time, whether you get it orally or IV. We usually use IV for patients that either can't swallow or they're just too sick. Yeah, we put it in IV. It doesn't mean it works faster. They work about the same. If you have time to do that with anaphylaxis, sure. But again, the main treatment is epi. Repeat the epi if you need to, and IV fluids. Right? For sepsis, IV fluids is a treatment. We don't have pressors on the ambulance. There's some questions about push dose pressors. If we use push dose pressors in the ER, I have lots of help, and I have a pharmacist 24/7 in the ER that can help me make sure that I dose the right thing. We have, I think they call them fennel sticks. So like they're pre-dosed or pre-drawn up in a very specific dose, trying to monkey with giving push dose norepi or push dose epi, something like that on the ambulance in a high stress situation, trying to make sure you don't give the wrong dose of something, I think is too risky. I don't think the juice is worth the squeeze to try to to get good at that. It's a very low frequency thing. It's a very high risk thing. So we're not going to do push dose meds at this point. I don't see it in the future. Maybe if something changes about that, or there's a way to package it easier, certainly things could change. But as of now, I don't think it's worth doing on the ambulance. So you can give a lot of AV fluid for sepsis. If you have somebody that's known they are sepsis, like your typical nursing home patient, like fever, they look terrible, like everything looks like, UTI or sepsis from some reason, and you're worried about their heart function, you can look with ultrasound and see just what their cardiac function is doing. It's rare that we actually put people into pulmonary edema with just a couple liters of fluid. And given our short transport times, we're probably not going to put somebody in pulmonary edema, even with pretty poor LV function. I shared a story of a couple patients I had. One we did put into pulmonary edema after he'd unfortunately been boarding in the ER for many hours and got upwards of 3 or 4 liters of IV fluid, right? And then he needs some Lasix and he had to go on BiPAP, so that it wasn't great for him. But again, that was lots of IV fluid, not the amount that you're going to get in a typical ER transport. And even if you have a mixed picture of some cardiogenic shock and some sepsis and you give fluids, if we have to take it off later with Lasix, again, we'll do what we have to do with that. It's not a huge deal. So I would say don't be scared of IV fluid. Certainly start with 500 is fine. If it's an old patient, you don't really know. But if they're still a little bit hypotensive, you can give more. So in most cases, we're not going to cause terrible pulmonary edema in most cases with the short time that we have for transport. Neurogenic shock is another one. This is kind of an outlier because typically patients are bradycardic. You get unopposed, and this typically is from level classically taught like T6 or above. You lose the sympathetic tone and you have unopposed vagal tone. So unopposed parasympathetic. So typically they're hypotensive and bradycardic, right? That's an odd one, right? Somebody who's bradycardic and hypotensive in a trauma setting, be thinking about neurogenic shock, like typically C-spine, but even down to the upper T-spine level. Medically, there's only a couple things that do that. It's like calcium channel blocker overdose and beta blocker overdose. Like when your body's hypotensive, the natural response is tachycardia. So if you're not getting the tachycardia in a medical setting, it's probably meds on board. In a trauma setting, think about neurogenic shock. Again, there's probably some outliers, but just off the top of my head, those would be the most common things to think of when you're hypotensive and bradycardic. And again, some IV fluid for neurogenic shock. Obstructive shock. So the big three are tension pneumothorax, PE, and tamponade. Tension pneumo, again, the right clinical context, penetrating trauma to the chest, increased difficulty breathing. You might see JVD, you might see tracheal deviation. Those are often very late findings. So in the right clinical context, if they're looking terrible, then they need a spear. So in the lateral chest. So for PE and tamponade, this is where I think ultrasound is more useful if you have a suspicion for that. Like PE, it's your typical, let's say they're post-op from a knee replacement. They have had lower extremity swelling for a couple days, maybe on the other side that wasn't the site of the surgery. And now their vitals are terrible. They're hypoxic, tachycardic, complaint of difficulty breathing, and it all happened pretty quick. PE should be pretty high on your list. When you look at the chest, trying to look at the heart, either subxiphoid, long axis, short axis, whatever view you can get. If you see a big right ventricle compared to the left, typically the right ventricle is kind of an add-on. Like the main part of the heart and the ventricle is, the left ventricle is the big, thick-walled part. The right ventricle is typically fairly small off the side, not as thick-walled. But if you see a huge right ventricle, or even pushing the septum into the right ventricle, or you just look at it like, I don't know, maybe you don't have your orientation, your probe right, you're looking subxiphoid, and I'm like, I see the ventricles, and they're the same size. If they're the same size, again, I'd be worried in the right clinical context about PE. Patients with pulmonary hypertension, like a long-standing issue, you can have a dilated RV as well. But in the right clinical setting, when you're thinking about PE, if the ventricles are the same size, or again, you see the septum moving, that would be important to know. You can give some IV fluids, but you need to get somewhere that can deal with that. There's not something we can really solve pre-hospital. So, same with tamponade. Tamponade typically in a trauma setting, again, penetrating trauma to the chest, be thinking about tamponade. In medical settings, it would be a recent procedure. So maybe they had an AV valve replaced. They maybe had a recent, an angiogram, and they got some stents placed. You could get a dissection of one of the coronary arteries, or a free wall rupture. It's where you have a heart attack, and now in the next week, it's like 3 to 7 days, somewhere in there, you get a free wall rupture. Essentially, they had a heart attack, and then that part of the myocardium died, and then that ruptures. So then you get tamponade. So again, ultrasound is useful to look at those things. And if you find something there, again, it's not therapeutic, but it's diagnostic. So if you get to the ER and you say, hey, I think the right ventricle looked pretty big. All right, they should key in on that and look at that closer. You think, yeah, I think I saw tamponade. And I don't care if you're 100% right. If you overcall it, I don't care. It's better for the patient if you're like, hey, I think this might be going on. And they look and say, no, it's just like a pericardial fat pad. That's not tamponade. Fine. No harm, no foul. But that would be a good time to try to use that if you can get a good view of the heart there. Cardiogenic shock, specifically talking about SCAPE, which stands for Sympathetic Crashing Acute Pulmonary Edema. And I think Sean probably sent this out, but there's a great MCRIT podcast, I think it's the first one that was done many years ago, that talks about that. And the treatment is nitro, and like a lot of nitro, and BiPAP. We don't have nitro drips. Again, with the short transport times, I don't think the juice is worth the squeeze to train up on nitro drips. But like 2 tabs of nitro under the tongue, I think is what our protocol says, and put the patient on BiPAP. And those patients can look really bad really fast, and they can also get better very quickly with the nitro and the BiPAP. So again, you could use ultrasound there to look at their cardiac function. It may not look too bad depending on what type of heart failure they have. So again, it's a diagnostic thing. It's not therapeutic, but nitro and BiPAP can quickly make these patients look great. You might get to the ER, you're going to the red room, and I would still go to the red room, but you may get there and like their vitals look great, their breathing is better, they're able to come off the BiPAP. That's all fine, but I would start there. If those patients look really bad when you get them, I'd probably go to a red room. And again, they may resolve just in that short time. It often resolves very quickly. It can look really bad really fast, and it can get better really quickly as well. The last one that I was going to mention here, we don't talk about a ton, but it's brain injury associated shock, typically with severe TBI. That can be isolated, or it can be in combination with other traumatic injuries. You could have bad head injury that's contributing to this, and again, typically tachycardic and hypotensive. So if you have a patient, big trauma, but you don't see much like external signs of trauma to the torso, I don't think I have blood loss here. Maybe you do a fast, like, okay, where they're not bleeding in their abdomen, they're hypotensive and tachycardic, it might be brain injury associated shock. That's kind of on a spectrum, because then if you get into Cushing's triad, which is like severe, like a huge subdural or epidural that's now squeezing the brain, then you're actually going to get hypertensive. So, and then when this gets really bad towards the end of this, when things are going really bad, either it could be from like a bad intraparenchymal hemorrhage, like 10% of strokes are hemorrhagic strokes, or intraparenchymal hemorrhage, epidural, subdurals. You actually get hypertensive, or bradycardic, and then you get like Shane Stokes respirations. So again, but something to keep in mind that you maybe have this going on if you don't have another source of bleeding, but just bad head injury. It's actually more common in kids that can have that. So something else to keep in mind. The last couple things that we talked about we talked about our case with pacing. And the main things that we talked about were pain and sedation for pacing. So your options are, that's not under the sedation and pain protocol. I believe there's a category in the protocol sort of like other procedures. So it's sort of paramedic discretion if you think they need pain or sedation. My point would be, if somebody acutely needs pacing, I would rather deal with the fact that they complained of the pain later than they didn't get paced. You give them some fentanyl or some Versed, and now they get more hypotensive, they get worse, and now they have an arrest. Now we're dealing with that. That's a much worse thing for the patient than dealing with the pain of the pacing. So I would say the pain or sedation, we certainly want to make them comfortable if we can, but that's not the priority. The best thing for the patient is to stay alive, and if that means pacing, and then they get some pain from that, if you maybe get a better blood pressure, their vitals improve a little bit, then you can give some pain and sedation. Versed also has the advantage that you get a little retrograde amnesia, so they maybe had pain when it was happening, but they won't really remember it. And again, the best thing for the patient is not to arrest. So if they need pacing, the pacing has to take priority over the pain or sedation, which potentially makes their vitals worse. So the other point about pacing patients, we talked about the transfer of care and the call where we had mutual aid coming in. So between ambulances, pacer pads, and monitors are not always the same. They're typically not the same going into the ER. There was a discussion about the lead placement, the 4-lead in addition to the pacing pads. And I don't do this regularly, right? I'm not on the ambulance, I don't do your job. But be very cognizant when you roll into the ER and say, hey, we're pacing this patient, it's a time for sure you want to make sort of a timeout. We talked about the handoff and what that looks like and the acronym for that. But very specifically in these cases, when you're handing care over to the ER, there's going to be techs and nurses and a doc that are all going to be descending on the patient. And the techs, if they're not thinking it, they're going to start pulling your leads off, start disconnecting your pacer pads, putting on their monitors, right again. So ideally, when you roll in like that, hey, just make sure you're clear with everybody. We're pacing this patient. All right, so get them next to the bed. Ideally, they're not crumping. Now that you're pacing, things are going better. You have a moment to say, let's make sure let's get the ER pacer pads on right next to ours. Let's get your 4 leads on, get your connected to your machines, and then we will disconnect our stuff. If you just roll in there and a tech starts pulling all your wires off, pulling your pacer pads off, now we're not pacing the patient, they're getting worse in the handoff. We don't need to do that. So if we made the patient better with what we're doing, we need to be extra aware of that and slow everything down a bit and make sure that the ER stuff is all set up before you get your stuff off. I mean, most patients, you come in with your 4 lead on and they're not crumping in that moment. If you just rip the pacer pad or rip the wires off and get theirs on, right, most of the time it's not a huge deal. But when it is a big deal, it's a really big deal. So just be cognizant of that when you're transferring care over to the ER. So that's all I got for this month. We'll see you again next month.